anatomy, the histology, and the function in this complex type of joint will include, first, it is symmetrical in the right and the left. So we have a right and left condylar heads of the mandible. We have the articulating surfaces of the mandibular condyles and the templar fossa, which are shown here in white. These are articular surfaces of the upper and of the lower one. Number 3 is the disc that intervenes between both the fossa and the condyle. And number 4 is the capsule, which surrounds and supportive ligaments all around. This is the capsule which is cut down. The fibrous articular disc, it divides the joint into two, into an upper half involved in the sliding movement, sliding action, and the lower half functions as hinge action. The joint is supported anteriorly by a tendinous attachment of the capsule and the lateral pterygoid muscle. This is anterior. Laterally by the lateral or the temporomandibular ligament, which is lateral to the joint. Medially, it is supported by the sphenomandibular ligament, one of the ligaments called sphenomandibular ligament between the sphenoid and the mandible, and most posteriorly by the stylomandibular ligament and what we call a retrodiscal pad or a retrodiscal lamina. We have said that the TMJ functions as a complex type of joint. We call it ganglio-arthrodial joint, which indicates that it moves both sliding and hinge movement. We will start now. Is it moving? We will start now about the mandibular condyle. Yes. So the mandibular condyle right and left heads of the condyles articulate in the temporomandibular fossa, or what we call glenoid fossa. At birth, remember that at birth we have heads of the condyle are round and covered with thick layer of cartilage that we see here. Okay, this is at birth. The cartilages are uneven, and we have cartilage projections into the underlying marrow spaces, or what we have the bone marrow space. The bone forms around these spikes, so the head of the condyle you see here, it's porous. It will be a porous cartilage cap. It is missing here because of tissue preparation, but we have a porous big cap at birth. This is at 6 years of age, or during development, the condyle will grow lateral direction. You see it will get bigger in lateral medial aspect, and they will change the ovoid shape into ovoid shape by maturity until the age of 25 years. Okay, so the oval condyle consists of smooth surface, a smooth bony surface covered with a layer of fibrous connective tissue in the adult condyle. The cartilage serves as a growth site in the condyle. So we'll have cartilage plus an overlying layer of fibrous tissue that we have talked about. Let's go here. So as new cartilage cells arise from the cellular layer of the perichondrium, the perichondrium which covers the condyle here. Here, as you can see, the cartilage zone, the cartilaginous zone, and the hypertrophic cartilage zone. We will talk about the covering of the perichondrium or the condylar layer. This is the covering condylar layer. The cartilage cells, they will grow and divide, and the cells here, And the cells in the deeper layers, deeper cartilage, they will die as the cartilage that surrounds these cells will calcify. So we will continue having continuous calcification of the cartilage cells. They will grow and divide to supply for growth. The calcified cartilage is replaced by bone from the underlying ramus. We still have, here we go, the underlying ramus. So it is replaced by bone. The hypertrophic layer here was replaced by the bone formation layer. After which the process here, this process will continue, the calcification, and during development will be gradual thinning of the cartilage layer, cartilaginous layer here. At maturity, the cartilage will be totally replaced by bone tissue. Here in C, you see the thin cartilaginous zone. This is the articular cartilage surface. Here is the upper synovial cavity and the synovium, but we care about the articular cartilage and the cartilage underneath. Here we see the comparison between the head of the condyle and the head in long bones. These differ. The long bones form from secondary ossification centers in the normal long bones, and compare it to the condyle where we have it's part of the mandible. Okay, so in the secondary ossification centers here, we produce cartilage bone junctions that are termed epiphyseal lines. These epiphyseal lines happen here, the lengthening of long bone, lengthening process. No epiphyseal line is formed in the condyle on the other half. Here we see the heads of the condyle will accomplish growth, much like that in the long bones. Differentiation of new cartilage appears, then cartilage matrix around these cells, cartilage matrix that will be replaced by bone. This is difference number one. Difference number two is that we have a cartilage cells are organized, the organization of cartilage cells. So what we said is the second difference in long bones, we have organization in long rows that approach the bony junction, whereas in the condyles here, we have the organization of the chondroplast is scattered. We have random arrangement, we don't have a line arrangement. The chondroplast will go through similar changes, cell enlargement, cartilage matrix calcification, then bony replacement in this site. The ability to modify the shape of the condyles through the cartilage bone, this cartilage bone remodeling, will allow the adaptation to functional stress, because we have different shapes according to different individuals. Okay, so this diagram showed you firstly the straight vertical rows of cartilage cells, and secondly the random arrangement of the cells in the condyle as opposed to the long bones. Last thing that I want to tell you is, remember that we've talked about the postnatal development of the mandible that is illustrated here at birth, and then 6 years and 8 years. We will have talking about the fossa, finish talking about the fossa, that is composed of anterior part, we have the eminence, normally, and posterior part, we have the depression, or what we call depression in temporal bone. The fossa is located posterior aspect of the zygomatic arch. This is zygomatic arch. We have the fossa, and Normally, the anterior wall of the wassa will be very smooth and it will form a tubercle. The tubercle here is the anterior, we call it eminence or a tubercle. It is the anterior limitation of the joint. It cannot go further except if it's dislocated. This is the shape in newborn. You see the junction of the temporal and parietal bones have some elastic fibers that will grow until we reach the articular fossa deepening during development to accommodate with the growing condylar head that will be located here as it enlarges laterally. Okay,